So, good morning, good evening, and good night from everyone across the globe that's joining us for this edition of the EIOC In Conversation series. We're going to be talking about the recent advances in future treatment landscape of hormone receptor positive breast cancer, really focusing on the integration of oral SERDs both in the early stage setting as well as the metastatic setting. My name is Shaheenah Dawood, and I'm a consultant medical oncologist coming to you all the way from the very sunny, very bright, and very safe United Arab Emirates. And I'm joined today by Peter Schmid, who is a KOL in this field, coming to you from the UK. Peter, please introduce yourself.
There's not much to say. Thank you, Shaheenah. I'm Peter Schmid, a medical oncologist, work at Barts Hospital in sunny London as well. Slightly colder probably than with you in the UAE.
So without further ado, Peter, take us through first, I think, the early stage setting, and then you're going to talk about the more advanced stage setting. And I think in between the two, we'll ask the questions that I think a lot of the community oncologists are actually wanting to deep dive into. So take it away, Peter.
Brilliant. Thank you, Shaheenah. Let me try and share my slides, if that's possible, and hopefully find the right slides. Otherwise, we have a slightly different topic. So ER-positive breast cancer and focus initially is on early stage disease. Just to really recap the absolute basics, which I'm sure you all know. Estrogen receptor positive breast cancer is obviously stimulated in its proliferation through the estrogen receptor activation, and that is often a co-proliferation driven by the cyclin D CDK4/6 interaction. If you want to use this therapeutically, we can interfere with this axis in two main points, either at the receptor level with SERM or SERDs, or we can stop the production of estrogen with aromatase inhibitors, as we have been doing for decades with aromatase inhibitors. Now, if you look at the whole concept of hormone therapy from a receptor point of view, and it is quite important to understand the different mechanisms of resistance and sensitivity. So if you look at in dark blue, the estrogen receptor, this gets dimerized and activated as soon as estradiol binds to it. And there are essentially three scenarios that are clinically important. The first one is if a tumor cell is truly estrogen receptor sensitive, it probably makes little difference which hormone therapy we give initially, because all those treatments work initially, but over time, mechanisms of resistance kick in. There are two fundamentally, in a very simplistic way, different mechanisms of resistance. One affects the estrogen receptor itself. And as you can see here with this green blob on the blue estrogen receptor, the estrogen receptor can be modified either through phosphorylation through different growth factor receptors or through the mutation of the estrogen receptor gene. The result is very similar. The estrogen receptor can be activated even if there's no estrogen around, even if there's no ligand around. That's why we call it ligand-independent activation. Now, in such a scenario, if you take estrogen away with an aromatase inhibitor, is this going to work? Unfortunately not, because in that situation, the estrogen receptor will fire even if there's no estrogen around, and we need to remove the estrogen out of the cell. The drugs that can do this effectively are so-called SERDs, selective estrogen receptor downregulators. I will talk about this in a little bit more detail. The second, and probably over time, at least equally, if not more important mechanism of resistance is what I would describe as alternative signaling. So if you have, if the cell can switch on additional pathways, for example, CDK4/6 or the PI3K/mTOR pathway, and then bypass the single signaling of the estrogen receptor. And in that situation, we need to bring two roadblocks in, combination therapy, which has become the standard of care in metastatic ER-positive breast cancer. Now, going back to early stage breast cancer and looking at recurrence over time, as you can see here, the shape of the curves, recurrence curve over time, are quite different for hormone receptor positive or hormone receptor negative disease. Now, whilst in hormone receptor negative disease, we have this very early peak in the first 2 or 3 years, and then a dramatic drop of the risk of recurrence. With ER-positive disease, we still have an early peak, slightly later, but what is really key to to acknowledge is the wide shoulder of the recurrence curve over 10, 15, even 20 years. So if you look at patients with ER-positive breast cancer, looking at the 3 or 5 year risk is insufficient because more than 50% of the recurrence risk will happen beyond the first 5 years. If you look at the drivers of the risk of recurrence, the clinical stage obviously we've known this for a long time, is a key driver. Looking here, for example, at the recurrence risk over 20 years for T1 tumors, depending whether they're N0, N1, or N2. You can see the risk of recurrence goes up as high as 1 in 3. We can see the shape of recurrence is relatively similar whether patients have stage 1, 2, or 3 disease, but obviously at a higher risk of recurrence. What's really where we're focusing on increasingly is the late recurrence risk beyond 10 years. And if you look at, for example, that yellow curve of node negative tumors, recurrence risk at 11% at 10 years, but goes up to double to 22% over 20 years. And I think that's something we need to acknowledge and consider when we design our trials and treat patients. And finally, obviously, the tumor biology also plays an important role in the risk of recurrence. Very clearly, a grade 3 tumor has almost twice the risk of recurrence compared to a grade 1 tumor, things we have known for a long time. If you look at the biological risk in a bit more detail, we can assess this, for example, with genomic assays. And as you're well aware, and you can see here in the slide, patients with low risk of recurrence have a much lower risk compared to high-risk patients and have ultimately more hormone-sensitive tumors. There's also a clear link between the recurrence score and the proliferation index, and patients who have a slowly proliferating tumor have generally a relatively low recurrence score as well. Now, one of the things that's really it's really important to focus is what is the risk of recurrence. We're all aware that patients with node positive disease have an increased risk of recurrence, but I think the group of patients with node negative disease is also very interesting. If you look at the recurrence risk of patients who are node negative and have low clinical risk factors, it is around 5 to 6%. Whereas if you look at patients who are node negative and have clinical risk factors, it can be over 7 years, as high as 70%. If you then go for 15 or 20 years, you can as well double that risk, and it may be as high as 30% in those patients. Now, clinical risk for this analysis was defined by criteria we know from the CDK4/6 inhibitor trials. So tumor size larger than 2 centimeters, or if T1, then grade 3, or grade 2 with either a Ki67 of 20% or a high recurrence score. So it is a group of patients node negative with a slightly unfavorable biology where we need to be aware of the fact that the risk of recurrence is probably higher than we often think clinically. What have we achieved over years with endocrine treatment options? Now, if you look at the left side, tamoxifen in the first instance, which was our first therapy, clear significant reduction of the risk of recurrence by about 30 to 40%. Important looking at the curves is the risk, the benefit for given with 5 years of tamoxifen increases over the first 10 years, and then the curves remain relatively parallel. What benefit give aromatase inhibitors on top of tamoxifen? Well, about a 16, 17, 18% additional risk reduction. And I think it's helpful to keep that number in mind when we look at some of the newer data. This 70% benefit has shifted our whole practice globally. With 70% benefit, we have practically shifted all patients from tamoxifen to aromatase inhibitors. And I think that's relevant to consider with some of the innovations that come through. Who need chemotherapy? Now, when it comes to the decision about chemotherapy in early ER-positive, HER2-negative breast cancer, we ultimately take 3 factors into consideration. You see in the top line, the nodal status, and patients with 4 or more lymph nodes are generally considered for chemotherapy, whereas in patients with 1 to 3 lymph nodes or node-negative patients, we need additional factors to consider patients for chemotherapy. And the 2 things we consider most is the menopausal status and then what we will call the genomic risk. And as you can see in patients who are node positive and postmenopausal, we generally only give chemotherapy for 1 to 3 lymph nodes. If patients have a high genomic risk, Whereas in patients who are premenopausal, the difference is really in that group with an intermediate risk score, where some of those patients will also be considered for chemotherapy. Now, one of the questions that is often asked is there a fundamental difference in the biology of between premenopausal and postmenopausal women? So are the tumors different, or is it just that we need to treat differently? An interesting data from a WSG trial, which is a randomized trial where patients with a low recurrence score obviously received endocrine therapy, patients with high recurrence score received chemotherapy. But the interesting group, the group of interest for us, is patients with an intermediate recurrence score. And those patients were selected for either chemotherapy or endocrine treatment based on the fact whether they responded to preoperative endocrine therapy. So these patients received 2 or 3 weeks of preoperative endocrine treatment, and then we looked at the downregulation of Ki67 in the tumor. 2 out of 3 patients had a response. 1 out of 3 patients did not have a response. And if you look at the outcome for those patients, patients who responded in this functional assay to endocrine treatment had exactly the same outcome as patients with low-risk disease, whereas patients who are non-responders have a higher risk of recurrence. And I think it makes sense to consider those patients for additional chemotherapy or possibly other treatment options. The last question really around chemotherapy and endocrine treatment in this setting was, is there a difference in how endocrine treatment works between pre and postmenopausal women? And again, if you look at the red or purple bar, this is the preoperative endocrine treatment response of patients who received aromatase inhibitor, postmenopausal patients who received aromatase inhibitor. And we see in about 80% of patients, it leads to maximum suppression of proliferation of Ki67. If you look on the other hand at the blue bar, this is tamoxifen in premenopausal women and clearly ineffective as a therapy. But what's really interesting, if you look at the green bar, this is patients who received ovarian function suppression and aromatase inhibitor, premenopausal women, and the endocrine treatment is as effective as in postmenopausal women. So that suggests and provides further evidence that it's not the biology that's different between pre and postmenopausal women, but the efficacy of the treatment and the need for ovarian suppression in those patients. Now let's move on to CDK4/6 inhibitors, which obviously have become standard of care in patients with intermediate or high-risk early-stage ER-positive, HER2-negative breast cancer. In blue, you can see the indication for abemaciclib, which is essentially in patients with 4 or more lymph nodes or 1 to 3 involved lymph nodes. If other risk factors are there, grade 3, large tumor size, or Ki67 more than 20%. Ribociclib as sort of the second drug that was developed, slightly wider criteria, including all patients with node-positive disease and node-negative patients as long as they have risk factors, T2 tumors, and then additional risk factors in that setting. And if you look at the follow-up data presented for abemaciclib, you can see it's an increasing benefit over the first few years with a hazard ratio, the last analysis of 0.73, so 27% risk reduction. And for the first time, we also see an overall survival signal, which I believe will get stronger over time. If you look at similar data with ribociclib, again, we see a very similar hazard ratio. We have similar widening of the curves over the first 5 years, from absolute 2.7 to absolute 4.5% at 5 years. And the benefits is seen both in node positive as well as in node negative patients. But it comes at a price, it comes at a cost, not just financially, but more importantly in terms of toxicity for patients. With abemaciclib in particular, gastrointestinal side effects. With ribociclib in particular, the liver function test will lead to discontinuation in probably around 15% of patients. And this is a slide I borrowed from Michael Gnand, which I think is really helpful, especially in premenopausal patients, how we treat these days. The lower the risk is, the less we do. Tamoxifen remains an effective treatment, but then in intermediate risk patients, we bring in aromatase inhibitors, ovarian suppression, and the higher the risk comes, also CDK4/6 inhibitor and possibly chemotherapy. Now, one of the areas we wanted to focus today is oral SERDs. And oral SERDs have become a group of drugs of huge interest and I think huge clinical relevance. The concept is, as we discussed earlier, they're not just blocking the estrogen receptor, but they're also degrading or taking the estrogen receptor out of the cancer cells. And there are subtle differences between the different drugs, or whether they are pure oral SERDs or circas, which lead to a covalent a binding of the receptor, or serans, or protax. Protax is probably a little bit different in the mechanism of action, as it leads to the increased degradation, not just through a ligase and then ubiquitination of the tumor cells. So ultimately, from a cancer cell point of view, the result is the same. We take the estrogen receptor out of the equation, and that's particularly relevant when there are any signs of ligand-independent activation. What about using those drugs in early breast cancer? And there are three possible scenarios how we can apply oral SERDs in this setting. The first one is an upfront strategy, replacing standard endocrine treatment with an oral SERD, and that can be done alone, or as a second concept in combination with CDK4/6 inhibitor. And the third concept is a classic switch strategy. Patients are on endocrine therapy plus minus CDK4/6 inhibitors for 2 years and then get switched to the other treatment. Now, there are a number of trials ongoing in terms of the switch strategies after 2 to 5 years of endocrine therapy. There are randomized trials with camizestrant, imlunestrant, and elacestrant pending, and we have to wait a little bit longer for the first results. But in terms of the upfront strategy, the two main studies, one with giredestrant called lidERA, and we'll share the results with you in a second, and then camizestrant, Cambria-2, which also allows a little bit of abemaciclib co-treatment. Now, the lidERA trial was the first oral SERD trial to read out in early stage ER-positive breast cancer. We saw the data at the last San Antonio meeting. And just to set the benchmark again, what we have achieved over time with endocrine therapy with aromatase inhibitors is a 16-17% reduction of further improvement on tamoxifen, and CDK4/6 inhibitor around 24-25%. So hazard ratio of 0.74, 0.75. That's the benchmark I think we are measured against. The background for giredestrant, it's a highly active drug, and many of you may think it's a drug we only use in ESR1 mutations, but actually if you look at ESR wild type, for example, cell lines here, you see a much more profound downregulation of the estrogen receptor activity and the growth rate with giredestrant compared to other endocrine agents. We see on the right side very similar results with in a preclinical window study, more profound downregulation of the activity compared to aromatase inhibitors. So the efficacy is not ESR1 mutant dependent. In fact, it's a highly effective drug and provides more profound downregulation of estrogen receptor activity in all cell line models. lidERA trial, 4,100 patient trial, randomized 1-to-1 to giredestrant for 5 years, a standard of care endocrine treatment for 5 years, which was single agent endocrine therapy without CDK4/6 inhibitor. Patients were stage 1 to 3. If they were at stage 1 disease, they required additional risk factors such as grade 3 or high Ki67 or otherwise node positive patients. Patients who were premenopausal required the co-treatment with ovarian suppression if they were on aromatase inhibitors or giredestrant, but not mandated for tamoxifen. If you look with a relatively short median follow-up of just under 3 years, 2.5 years, we see a meaningful improvement in IDFS, in invasive disease-free survival, hazard ratio 0.7. That compares very favorably to what we've seen with other endocrine treatment options in the past, and the benefit is seen whether patients had aromatase inhibitor or tamoxifen in the control arm. If you look at distant, so metastatic recurrence-free survival, again, the hazard ratio of 0.69, significant and meaningful, and that means we will see a long-term survival signal if you just wait long enough. At this point in time, this is too early. You see a very early separation of the curves with a hazard ratio of 0.79, but of course, with under 3 years of follow-up, we will have to wait longer for that. What's the cost for this treatment in terms of patient side effects? If you look at the tornado plots on the left side, it looks very similar to standard endocrine therapy. There are a few subtleties I think that are really important. Now, if you look at the joint arthralgia, which is obviously the number one side effect patients describe, but actually a lot of these patients already have joint pain at the start, before the start of therapy, because we are looking at postmenopausal women in their 60s, 70s who have achy joints very often. So possibly a more relevant marker of assessing the significance of the impact on joint pain is looking at the discontinuation rates. And you see this in a table on the right. More than double as many patients discontinue endocrine therapy with aromatase inhibitors, standard of care endocrine treatment, because of musculoskeletal problems or joint aches compared to giredestrant. So giredestrant seems to be favorable in tolerability from a joint point of view. In the bottom half, you see data on bradycardia, and that's one of the side effects that was observed on an ECG for patients on giredestrant. But interestingly enough, the bradycardia there is what I would call inducible, which means if you have, for example, patients on a beta blocker and you want to get their heart rate up, that's really difficult. If they run up the stairs, that's difficult for the heart rate to adjust. With giredestrant, if patients need to exercise, if they have a slower heart rate, you send them up the stairs and the heart rate will go up. So clinically, bradycardia is not an issue and not a concern. What's the clinical impact of this trial at this point in time? Obviously, it's a big step forward. It's the first approval of an endocrine treatment, not a co-treatment, in actually 30 years. SERDs obviously were never approved in the early disease setting. If you look at the dimension, the size of the benefit, it compares very favorably to the relatively modest benefit we saw with aromatase inhibitors, hazard ratio 0.81, 0.83. And we have a hazard ratio 0.7 at this point. So this is a very big step forward from my point of view. There's still a massive need for patients out there. You can see here the risk of recurrence in real world data, which is as high as nearly 50% at 10 years. And although we are treating more effectively, the risk remains still high, especially if you look at 10, 15, 20-year data. We have looked at those data earlier, but if you just focus on the first 5 years, we will underestimate the risk of recurrence. One of the key points that is really difficult to capture in data is adherence, treatment adherence, or we used to say compliance for patients. So that the best treatment doesn't work if you don't take it. We know from data, and as you can see here on the left side, up to 40% of patients are essentially not going to take their treatment. And some studies even suggest up to 50% of patients. And if you look at the right side, you see in blue patients who continued and or were adhering, and in red patients who were not. And you can see very clearly that the outcome is substantially inferior if patients don't follow through with their therapy. Now, if you look at the benefits of giredestrant compared to the benefits what we've seen with ribociclib and abemaciclib, and obviously at the different time points, we have longer follow-up for ribociclib and abemaciclib, but at the 2 and 3 year mark, the data look remarkably similar in terms of the hazard ratio, in terms of the absolute delta of the benefit, especially with NATALEE and lidERA, which are similar risk profiles. And we have to wait, obviously, for 4, 5, 6 year data to be able to compare that. But what we've learned from tamoxifen, from aromatase inhibitors, from all endocrine treatments is that the benefits with endocrine treatment seem to widen throughout the time patients are on and possibly beyond there. So I'm confident we will see even wider curves as we go along and have further follow-up. Final points are a little bit about toxicity. Obviously, we are aware of the toxicity with CDK4/6 inhibitors, and that is clearly an area where a single-agent endocrine therapy has advantages. But also, just looking at real-world data of discontinuation rates, they are in the 15 to nearly 27% range, and that needs to be considered. So this is what I wanted to share around the early disease setting. And Shaheenah, I'm not sure whether we have some discussion now or whether we
Yes.
move on with the metastatic stuff.
No, I'd like to ask you a couple of questions now. Thank
Brilliant.
you all for an amazing overview of the early stage setting. I think lidERA has put a spanner into our enthusiasm for everyone getting a CDK4/6 inhibitor, because you might think about a population where you potentially might not need to give a CDK4/6 inhibitor with the use of an oral SERD. So my question to you is, lidERA and Cambria-2, I don't think that they're going to be able to answer the question of if you added a CDK4/6 inhibitor, would you get a bigger benefit or would it be the same benefit with an AI? So where do you see an oral SERD being used in that early stage setting going forward?
So, really good question. And of course, I haven't got a good answer to that. So I can answer this in different ways. So if we had 6 or 7 year follow-up data with giredestrant, they showed exactly the same trends continuing, and we would have the same robustness of data as we have with abemaciclib and ribociclib, you would say those data look practically identical, and you have a better tolerated version. And I think in those situations, some of us would be tempted to say, actually, I'm replacing one with the other. I think at this point in time, it's a little bit too early because we haven't got those 6 or 7 year follow-up data for the full replacement strategy. Now, there are obviously groups of patients who were on lidERA, who were not in NATALEE and Monarchy. And those patients, I would give the drug today if I could. For example, the stage 1 patients. There's also a group of patients who have to discontinue CDK4/6 inhibitors, and that's about 15 to 20%. Again, this is a group of patients where I would do this today if I could. I think there's a third group of patients where a lot of clinicians feel a bit uncomfortable about giving CDK4/6 inhibitors. If you look, for example, at the well-behaved node-positive patients,
Exactly. The
they
low risk
sometimes,
node positive.
yeah, they have sometimes a better clinical outcome
Yeah.
than the poorly behaved or poor biology node negative patients. And I think this is a group where, again, where many of us would be very happy to give an oral SERD instead of a CDK4/6 inhibitor. But I think the big question going forward is if you look at the mode of action, they should be complementary. So there's no reason why we shouldn't be able to combine both drugs and have additional benefit, because one tackles the ligand independent signaling, the other one tackles the alternative signaling. And I think those effects should be at least additive, possibly synergistic, but of course we have to generate the data for that.
So then my next question is, and it's sort of going on to what you're saying right now, we've seen in the metastatic setting, and of course the data has not been published yet, but we've seen a press release that at least in the metastatic setting, giredestrant plus a CDK4/6 inhibitor versus AI plus CDK4/6 inhibitor in that first line setting, irrespective of an ESR1 mutation or not, they're doing exactly the same. It's not a positive study. So why would we not expect something similar in that early stage setting?
Yeah, great question. So first thing is none of us has seen the curves of the Persevere study, which is the
Yes.
first line study, and I'll talk a little bit about that in the next in the metastatic section. So long-winded answer. First thing is if you compare fulvestrant with anastrozole, the good old Falcon trial, interesting trial, super sensitive tumors, never seen hormone therapy. And if you go back to one of my first slides, a sensitive tumor will respond to any endocrine therapy. And that's what you see in Falcon. The first 6 months, 3 to 6 months, the curves are totally superimposed. And then they start to separate because then fulvestrant is better than aromatase inhibitor. The overall hazard ratio ends at 0.79, and the way the trial was designed, that was positive. But it comes down to that separation of the curve. Now, what would have happened if you added a CDK4/6 inhibitor into Falcon, and that's basically what we did in Parzival, you dilute that effect a bit because the CDK4/6 inhibitor pushes that separation curves further down the road because it makes resistant tumors respond a little bit longer. And so if you reading or hope I might be reading too much into the press release of Persevera, but the way I read this is it's a statistically negative trial, but there's a clear signal of a benefit there. And my speculation is, I haven't seen the data, is that we see a separation of the curves after 9 or 12 months. And this is when the superior efficacy of the treatment kicks in and when the curves are starting to separate. Now, depending on the statistical design, it then seems to have turned out that this was not significant, but it doesn't mean that the combination didn't show a benefit. What's different in the very early disease setting is the early disease setting, we are not giving both drugs forever.
Yeah.
With in the metastatic setting, both drugs are always given forever, and the recurrence happens over a much shorter period of time. Whereas here, I think we cover some of the pre-existing resistance with the CDK4 activity right at the beginning, but we carry on for another 3, possibly 5 years after CDK4/6 inhibitors with the oral SERD, and I think there's a very good chance that we will have benefit from both strategies and therefore an additive or synergistic benefit.
My next question is, and I'm not sure you have the answer for this, you do have patients that did recur in the lidERA study. The patients that recurred, has there been any translational data that's come out for that in terms of looking at biomarkers like development of ESR1 mutation or not? And what has happened to those patients who got giredestrant and also relapsed?
Yeah, great question. Too early for that. We haven't got the data. And of course, these trials can only give us so much in terms of information. It's the same thing as we have with the CDK4/6 inhibitors, where we are now starting to learn what happens in those patients who are treated outside trial. And for example, they're learning that probably a third to half of the patients turn actually triple negative when they recur. But we don't know
Exactly.
this yet for oral SERDs.
And then my final question before we go into the metastatic setting is, say suppose giredestrant is actually approved tomorrow in the clinic, and we have, longer term follow-up data, and we see that the hazard ratios are following a very similar path to Monarch E as well as Natalie. What is the ideal duration of giving it? We
Mm.
know that, 5 years is probably what we would give, but we also know that giving extended endocrine therapy benefits patients as well, especially for that long-term recurrence. So how would you give it in the clinic? Would you give five
So
years and then switch over to something else? Because that's the question that's going to come up in the
that is a
community.
question that will come up. You're absolutely right. But we mustn't forget that the majority of patients who are on lidERA and similarly on other studies that are coming have not completed their treatment yet. These are young studies. So it is not inconceivable that some of those trials may be adapted now that we know we have positivity to allow actually 7 or longer years of therapy. And so I think as we grow older, as the data mature, we will also get longer follow-up data. And don't think we will stick to just 5 years. The switch strategies already have 5 years of therapy after 2 to 5 years of treatment. So I think we will ultimately extrapolate, but also generate more data on longer use of oral SERDs.
Okay, so let's deep dive into the metastatic setting.
Metastatic setting. So same cartoon as you saw before, and I think this is probably even more important in a metastatic setting. So a sensitive tumor responds no matter what, but then we have those two mechanisms of resistance, ligand-independent activation, where we need to remove the estrogen receptor, and alternative signaling, where we go in with combination therapy. And if you look at this, I've called this the key pillars of endocrine therapy. We obviously target the estrogen receptor at the moment. We targeted cell cycle, and we target clinically the PI3K/AKT/mTOR pathway. If you look at some of the data we have generated over time, there are massive changes, especially in the second line setting. First line, standard of care remains and is probably not going to change. Combination endocrine therapy with CDK4/6 inhibitors, backbone dependent on whether patients are sensitive or resistant, AI or fulvestrant. And then second, third line endocrine setting, that's where different treatment options come in. In the past, we then would have said at some point patients become hormone refractory, we switch to chemotherapy and all the different ADC strategies. One of the interesting discussion points is do we need to redefine what hormone refractory is? Does every patient need to go through 3 lines of therapy? Or some patients who have quick progression after 5 months of AI and CDK4/6 inhibitors, maybe they are already hormone refractory after even 1 line of treatment. And these considerations and discussions are ongoing. Now, where most of the changes in the last few years took place is in the second or the pre-treated session, where we are now treating according to mutations of the estrogen receptor ESR1 with oral SERDs, PIK3CA/AKT with the relevant inhibitors, and then no mutations is a little bit trickier, whether we give CDK4/6 inhibitors beyond progression or everolimus. We also have now data in a small group, high-risk situation with a PI3K mutation where the triplet shows fantastic activity. And we will talk about treating the emergence of ESR1 mutations in the SERDs trial, whether or not that is ultimately a viable strategy. So if you focus on the estrogen receptor and oral SERDs in metastatic ER-positive breast cancer, or SERDs in the wider meaning, on the right side you see the Veritech trial. That's not a SERD, that's a PROTAC trial, but similar principle, estrogen receptor taken out, vepdegestrant is the name of that drug, and then SERDs, elacestrant, and imlunestrant, single agent therapy in pre-treated patients. Most of them had CDK4/6 inhibitors. Data, again, as always, remarkably similar. We have significant meaningful improvement, hazard ratio around 0.6, but only in patients with ESR1 mutations. Whereas patients with wild-type tumors, we may see a signal, but it's not significant, and we can discuss what that means. So again, often people interpret it, these drugs don't work in wild-type tumors. That's incorrect. It just means in wild-type tumors in the metastatic setting, they are not superior to standard treatment, but they're still highly effective treatments. Can new endocrine treatments improve overall survival? It's difficult to show this in clinical trials. If you look at here, data from the EMBER trial, single agent imlunestrant versus standard endocrine treatment, that is a very clear survival signal. Hazard ratio 0.6, p-value 0.0043. But again, the pre-specified threshold was ridiculous with, I think, 6 or 7 nodes there, and therefore it wasn't met at this time point. But I think most of us would look at those curves and said, okay, that's a survival benefit. The rest is ultimately trial design. Now, should we consider switching endocrine treatment when mutations occur before tumors are actually progressing? And this is the question of the PARA-1 trial that led to SERENA-6, AI plus CDK4/6 inhibitor therapy. Every 2 to 3 months, liquid biopsy to check for an emerging ESR1 mutation. And in those patients who did not progress but have the mutation, they were switched to camizestrant plus CDK4/6, so oral SERD, or AI plus CDK4/6. Now, it's an interesting trial. It's a fantastic trial academically, but it also has its challenges. If you look at the median time to randomization, 2 years, that's a long time. These are sensitive tumors. If you look at how many patients were screened, 3,300. How many patients were randomized? 315. Less than 10% of patients were randomized. 90% of patients went through all those assessments for no benefit. But if you ignore all of that, look at the results, fantastic results. Median PFS goes up from 9 to 16 months, hazard ratio 0.44, and that benefit seems to be carried to some degree over into the next line, progression-free survival too. Is this a standard of care? Can this be a standard of care? There are a few things to consider. One is, obviously, this is a slightly disingenuous design if you zoom in from the time point when the mutation occurs rather from randomization. If you had added 23 months to those curves, the results wouldn't have been significant. The second point I think is really interesting. We saw this in a phase 2 trial that with camizestrant is given that we can actually get rid of the ESR1 mutation. And so what I would like to see is what happens to the ESR1 mutation. Is it just suppressed, or when the tumor progresses, does it come back? Or can we really fully reverse some of the emerging resistance? If so, that would be a motivation to give these drugs early. The third point is it's difficult to interpret the data because there's obviously an imbalance in terms of access to endocrine therapies. Patients in the control arm did not have access to oral SERDs. And we know that would have led to a PFS benefit of around 8 months. We saw this in all the other studies I just shared to you. We also know that patients in the control arm didn't have access to CDK4/6 beyond progression, which again improved the results. So interesting trial, but not entirely sure what we do with it at this point in time. Here's what Shaheenah already mentioned, first-line trials, Persevera, SERENA-4. Persevera, we had the press release, and that is negative. But look at the Falcon trial. It's what I tried to describe in words. The curves are overlapping in the first 6 months, and then they start to emerge. If you put a CDK4/6 inhibitor in there, that pushes us a little bit more to the right. And my gut feeling is that's what we're going to see with persevERA. Now, looking at the second pillar, PI3K AKT inhibition, alpelisib, obviously highly effective drug, unfortunately also quite toxic, not just hyperglycemia, diarrhea, but stomatitis, rash, and fatigue is difficult for patients, and therefore in our clinical practice plays less of a role and has been more replaced with AKT inhibitors, capivasertib, which shows a similar benefit, but at a more favorable tox profile. Ipatasertib trial, probably a little bit too small to be practice changing there. Now, this is not second line, this is now first line, but I wanted to share those data because I think they're really interesting. This is a small group of patients, around 15% of the overall population, who have signs of resistance, so they relapse within a year or on adjuvant endocrine treatment, and also have a PIK3CA mutation. And in those patients, doublet, CDK4/6 fulvestrant versus triplet was investigated. And what I find fascinating is how poor the performance of standard endocrine therapy is in those patients. PFS 7 months, and we push this up to 17 months, 10 months delta, hazard ratio 0.42. That's really meaningful. That's significant. Objective responses, these are patients where we're often anxious to give chemotherapy. You can see the response rate goes up to more than 60%. TDXD just about achieves that. So this is highly effective therapy, even if patients need a response. Duration of response, again, 8 months delta. And the final point, I think is really interesting. Time to chemotherapy, 35 months or 3 years as compared to 1 year, 2 years delta. Clear benefit for patients. That's a combination we need to look more into and use more for those patients. And the final point around this is oral SERD combinations. Why have I taken that out and singled this out? One of the problems I have when we treat clinically, if you give combination endocrine therapy in first line, you put 2 roadblocks in front of the cancer. The cancer grows, you shift one roadblock and remove the second one. That's counterintuitive for me. And our experience with elacestrant, with the oral SERDs single agent, is not overwhelming. I know the trial data, but in clinical practice, patients don't do that well with single agent therapy. Just to support this a little bit with data, if you, for example, look at the fulvestrant control arm, Capitello, you see a median PFS of 2 months after prior CDK4/6 inhibitor. If you look again in a different way at the oral SERD trials I shared with you before, with a positive hazard ratio, but look what's happened in the first 2-3 months. 40% of patients have absolutely no benefit and progress at the first scan. So single agent therapy is not ideal in this setting, and we really need combination strategies for second line endocrine treatment in my point of view. There are 2 trial concepts that have been interesting. One is from the EMBER trial again. EMBER trial, frustrating trial. As a scientist, I didn't like the trial design because it wasn't pure. As a clinician, I love the results, and I think that the results are really interesting because that highlights the way I like to treat. If you look at imlunestrant, SERD alone in combination versus imlunestrant plus abemaciclib, significant, meaningful improvement, hazard ratio 0.59. Regardless of mutation status, we see the benefit in wild type and mutant patients, and after prior CDK4/6 inhibitor or not. So this is a great combination, but outside the US, very difficult to use. It's not going to be approved in that combination, although my American friends said that has become very rapidly one of their standards of care in a second line setting, unfortunately not in the UK. The second option here is the EVERA trial, which brings us back sort of an old track we weren't particularly keen on in the past, but have learned how to manage side effects. So this is a pure combination trial after CDK4/6 inhibitors. Every patient gets everolimus, and either with standard endocrine treatment, exemestane or fulvestrant, or with giredestrant as a backbone. Again, I like the fact that fulvestrant was allowed in the control arm because that's one of the shortcomings of the classic everolimus studies that is just allowed with exemestane. 1-to-1 randomized, Patients were allowed to be with or without ESR1 mutations, but it was one of the stratification factors. And if you look at the investigator assessed progression-free survival in the ESR1 mutant population, doubling of PFS, hazard ratio 0.38, 10 months versus 5.5 months, significant, in my opinion, also meaningful. In the ITT population, looks very similar, hazard ratio 0.56, 8.8 months versus 5.5 months, again, an important improvement. If you look a bit across other endpoints, response on the left, duration of response on the right, and there are three categories: mutant patients, ITT, and patients with wild-type tumors, no mutation detected. And actually what's striking is we see a benefit in terms of response and in terms of duration response, regardless of whether patients had a mutation or not, and we can discuss why or not that might be. If you look at the overall survival data, on the left side in patients with mutations, on the right side in the ITT, very clear signal that overall survival will be positively affected by switching the endocrine backbone to giredestrant. And if you look at PFS and overall survival in patients who are ESR1 wild type, again, we see a signal here. What's the cost in terms of toxicity? Tornado plot, very, very similar, obviously dominated by the side effects of everolimus, but no difference from the endocrine backbone. And I think we have learned a lot about how to manage the symptoms and side effects of everolimus, from oral swish with dexamethasone mouthwash, which really reduces the risk of stomatitis, to what we do outside clinical trials, wasn't allowed here, the slow increase with 5 milligrams, then to 7.5 and 10 milligrams if patients tolerate it well, and that will improve further the tolerability. So for me, the differentiating factors is obviously a significant benefit post CDK4/6 inhibitor, fairly well tolerated compared to the control arm. It's a simple trial, and we can discuss whether or not we need a biomarker for that. So where are we with our endocrine treatment options now? You see this pink round bubble I've put in there, which I think is really important, that we try to have combination therapies here, whether that's SERD plus mTOR or certain CDK4/6 inhibitors. That's for me a key step forward for both patients without mutations as well as for patients with ESR1 mutations. And that's the way I ultimately would like to treat those patients. That's what I wanted to share for now, and look forward to having more discussion. Thank you.
Thank you, Peter. I think the landscape of ER-positive metastatic breast cancer has really exploded with a lot of options. I have several questions. The first is, when you see the results of Elevate, which gave a combination of abema or everolimus with elacestrant, and you look at the results of Amber, and then you look at the results of Avera, at least it seems to me that in 2026, we should not be using oral SERDs or any type of endocrine therapy as a monotherapy strategy. Is there a group of patients where you would still use endocrine therapy monotherapy as a strategy?
So we struggle in the UK to do things that are not approved. And therefore we use
But if it was approved and everything was available to
so
you.
if I was allowed to do what I want to do, I would practically never use an oral SERD on its own. I think there are very few scenarios where you can imagine that with a very slowly growing tumor, but with the low tumor burden, where you have a high allele frequency, and you know your mutation is driven by the ESR1, your resistance driven by the ESR1 mutation. But even in those tumors, I would be tempted just to keep the CDK4/6 inhibitor in there and just switch that, similar to SERENA-6, but also to the Amber trial. So I think we have, years ago, I was saying, does everyone in first line situation need combination? And again, we still can come up with scenarios of patients who do really well on letrozole alone. But in reality, I think we're all giving combination with CDK4/6 inhibitors to 90-95%, if not more, of patients. And if we apply that principle, then I would say the same applies to then the switch in the endocrine backbone. I would like to give combination therapy to the vast majority of patients.
So with an extension on your thoughts over there, Say, suppose we have the approval for Avera and everything's available to you, and the patient has progressed on first-line CDK4/6 plus an aromatase inhibitor. Why would I switch to everolimus and not just continue CDK4/6 and add on giredestrant?
Yeah, it's a good question, and ultimately, I don't think we have a comparison of those two strategies at this point in time. Now, um, the treatment beyond progression with the same endocrine backbone had a hazard ratio in the zero point 0.7 and a bit range. So actually, it shows a benefit. We, on the other hand, we saw obviously when we switch to to an mTOR inhibitor, we see a slightly better hazard ratio, but we also have to accept some toxicity. So I don't think anyone can really answer this clinically. I like the concept of I would probably switch the class of CDK4/6 inhibitors, but that's a slightly nerdy thing. But I know that Ribo and Palbo have identical mechanisms of resistance. Abema is a little bit different. So if patients were on first-line ribociclib, then I like that strategy, switching to giredestrant or a different oral SERD plus abemaciclib. I think that's a very good strategy from a patient perspective. Everolimus, of course, is also an excellent strategy. But one could also argue, why don't you give it as a third line option then, when you have more resistance kicking in? So
Absolutely.
it comes down to how much are we allowed to do outside clinical trials. But the key message for me is I would like to use an oral SERD, but in combination with a second drug.
Now, when you look at oral SERDs and you look at Emerald and you look at the Serena 2 study and you look at Amber 3, where they looked at single agent oral SERDs, you see a 60%, at least a 60% drop in that Kaplan-Meier curves, where patients are just not benefiting from anything in
Yeah,
terms of endocrine therapy. Then when you move over to Amber 3, you see that there is a drop, but the drop is about 15%. Then
yeah,
when you look at Avera, there's still a drop, but I think that drop is less than what I saw in Amber 3. But again, this is just visual appreciation. Then you go on to Serena 6 and you don't see any drop at all. And I heard you say that you don't know if that would be the right strategy to actually implement in the clinic. But for me, when I'm looking at it, I see a group of patients where you are actually able to give them an oral SERD and there's no drop off whatsoever, because these are patients where there's no radiological progression of disease.
yeah.
So why would I choose, say, a first line strategy with CDK4/6, wait for progression and then go on to Avera or Amber 3 versus switching over to Serena 6, where I'm not going to lose any patients?
So these are obviously totally different strategies, and Serena 6 is you treat patients who haven't got disease progression, and you could also saying you're playing a card at a time when you don't need to play that card, which you can't play later on again. And so I don't know whether this strategy will ultimately be superior or possibly inferior because we give away treatment options at a time point when we don't need to do so. So that's why I sort of reserve my final judgment on Serena 6 because I think we need to get more data. I want to see that ESR1 permanent clearance rate as well as see what impact they could have on survival. But even survival is confounded by the fact that the two arms aren't balanced. So what the child doesn't test is early versus late introduction of an oral SERT, and that's what we wanted to see. Yeah, we want to
Yes.
see if you go in earlier, you have a long-term advantage compared to going in later, because patients in the control arm didn't get oral SERTs. That's for me the major downfall of the trial, because that's what I want to know. I know that oral SERDs are better whenever I use them if there is an ESR1 mutation. And again, what's interesting about that trial, if you think about tumor biology, so if you have a tumor that's on average responding well for 23 months, that's a long time. That's that. And then an ESR1 mutation is kicking in. You know that that mutation is driving the resistance. It's a very different situation than having a patient who has progressed and we find a ESR1 mutation, but the resistance may be driven by something else. And so I think these are biologically different scenarios. That doesn't mean that one treatment strategy is superior over the other.
In terms of, and we have just a couple of more minutes, but when I look at the data and I look at Avera and Amber 3, um, what I see is a group of patients who will also benefit from the combo of an oral SERDed plus something, irrespective of the ESR1 mutation. And the same I saw in the Elevate study as well. So do we really need to be testing for an ESR1 mutation to begin with, or should everyone in that second line setting be getting an oral SERD plus minus CDK4/6 or everolimus?
Well, it's a great question. And I think it comes down to resources, if you're honest, because we know the drug is, or the group of drugs is better, at least equal, but in most situations better, and in most situations also better tolerated. So it ticks both boxes, but it may be a little bit more expensive. And so that's the elephant in the room. If the drug was costing exactly the same as every endocrine backbone, I would switch every patient's second line to an oral SERD and then put in the combination treatment there. And the reason why we said we're only focusing on the ESR1 mutant patients is because that's where we see the overproportional advantage in single agent therapy. In combination therapy, that goes out of the window. You're absolutely right. I would much rather use those drugs because they're ultimately more effective. But we will need to see how politics pans out and whether we're allowed to do that long term.
And then finally, with the use of adjuvant CDK4/6 and not so far off adjuvant oral SERD, how is that going to impact first line therapy in the metastatic setting?
Absolutely no idea, but we'll hopefully see fewer patients relapsing. Now, that's always the key thing. I mean, it's as always, we have to work it out. I think it's for CDK4/6 inhibitors, it's a question when they relapse. So if they relapse a long time after CDK4/6, we still see sensitivity. If they relapse on it, then obviously they're resistant. With oral SERDs will be interesting because these patients are more likely to relapse on it because if you give that for 7 or 10 years, and we just have to study what those tumors are like.
So let me give you a clinical scenario in the last minute. You have a patient that has relapsed, say, 6 months post completion of a CDK4/6 inhibitor, has an ESR1 mutation, there's no PIK3CA mutation. What would be your ideal first line therapy for that patient in the metastatic setting?
You were
And you
too
have everything at your disposal.
you were too fast for me. Can you?
6 months post completion of adjuvant CDK4/6, has a relapse and has an ESR1 mutation.
Interesting. Um, so I think the key thing here for those patients post CDK4/6 is that we rebiopsy them. And
ER/PR positive, HER2.
that's really
Yes.
that's a requirement because about a third to 50% turn triple negative. Now you want to go in with a form of combination therapy, don't you?
Yes.
So you want to give in you want to ideally have a SERD because of the ESR1 mutation. That's a great combination for everolimus. We
So that
got that
would
in
be your
most of them.
lidERA
That is
protocol,
that
right?
that is your Ivera patient. I think
Sorry, Avera protocol.
yeah,
Sorry, yes. Yes.
that's a great option for that.
Yeah.
And I think there you need a single agent. I would be hesitant.
Okay, so we're at the top of the hour. It's been an excellent session. Thank you, Peter, for walking us through the enormous tsunami of data that we have in the hormone receptor positive realm. No doubt oral SERDs are here to stay. How we sequence, how we use it is going to be the next question that we're going to ask in the next couple of years. So thank you, Peter, and thank you all for joining us for this edition of the EIOC in Conversation series. Thank you and take
Brilliant. Thanks, everyone. See you soon.
bye. Bye bye.
Bye.